Yes.
Thank you, Sir Brian. I'm now going to move on to speak about what we have termed response to infections, which is a chapter found in chapter 6 of our written submission on behalf of the boards. The inquiry has examined in detail the way in which NHS organisations responded to diagnosis of infections in patients when tests became available. Firstly for HIV in 1984, and then hepatitis C in 1989. Quite appropriately, much of the focus has been upon the circumstances in which patients or their parents were first informed of the diagnoses. The inquiry has also examined in detail issues such as the provision of pre-test and post-diagnosis counselling, as well as the quality of treatment given in relation to infections. Certain aspects of this evidence have given the boards much to reflect upon, and we would like to take this opportunity to highlight these. Firstly then, dealing with HIV testing. By way of preface, may I say that in the board submission, it would be appropriate for your evaluation and assessment of the response by individual clinicians to the discovery of HIV infections amongst their patients to reflect and acknowledge the reality of the working conditions within the NHS in Scotland at that time. In particular, we would suggest that the evidence you have heard has illustrated how, in the absence of effective organisation at national or local level, individual clinicians were to a great extent left to their own devices in deciding how to respond, and at a time of acute professional anxiety and distress. Moreover, the evidence indicated that there was little in the way of guidance and direction such as would be available today to ensure the appropriate response. Indeed, the stark contrast with the coordinated national and local response during the COVID pandemic, which played out in real time whilst the inquiry was examining these very issues in its oral hearings, will not have been lost on any of those involved. Then, as now, the importance of NHS boards' responsibility to ensure that their clinicians are provided with the requisite support to navigate such testing circumstances cannot be overstated in our submission. The boards entirely accept that, largely as a result of these factors, the response within the NHS in Scotland was deficient in a number of respects. In particular, the boards are sorry that the process of informing patients in Scotland of positive test results for HTLV3 was too often characterised by unacceptable delay. The inquiry has heard a substantial quantity of evidence, in particular relating to the haemophilia centres at Edinburgh and Glasgow, as to the circumstances in which those delays arose. I don't propose to rehearse the detail of the respective chronologies involved. You have that evidence, sir. But for today's purposes, suffice it to say that these delays were unacceptable. They should not have happened, and the boards are very sorry for that. But if I may touch briefly on one specific matter in relation to Edinburgh and the group meeting that took place at Edinburgh Royal Infirmary on the 19th of December 1984, we also say that on any view for patients to be informed of the possibility that they were infected with HIV in such a public forum before having been given their own individual result was regrettable. It should not have happened. That is so for a number of fairly obvious reasons, which we do set out in the written submission, and the boards expressly apologise for that. And may I reiterate that the boards deeply regret the delay and the inevitable suffering that will have caused to the patients, will have been caused to the patients and their families, and take this opportunity to publicly apologise. Finally, on this issue, it is important to say that in our submission, these events provide an object lesson as to why decisions about crises of this magnitude should not have been left to a single individual clinician to make and manage in relative isolation without the necessary advice and support which both doctors and patients were entitled to expect from the board as the employer and treatment provider. The boards are therefore also sorry that their clinicians were not better supported during this process. I want to say something now about counselling, pre-test counselling. Where it occurred at all, the evidence indicated it was not always adequate. In that connection, we submit that Professor Hahn's rather self-critical evidence perhaps exemplified the effect of the emergence of HIV in encouraging a greater recognition within the medical profession of the importance of pre-test counselling as part of the testing process. Stigma and prejudice. It was clear that the NHS in Scotland was not immune from the ignorant and reactionary attitudes in relation to HIV, which permeated wider society in the UK at that time. The boards regret that hospital policies were promulgated which both reflected and encouraged these prejudices, such as blanket procedures for reverse barrier nursing of haemophiliacs. You will recall the troubling evidence from Professor Hahn of portering staff at York Hill Hospital refusing to assist children with AIDS. Nor was the problem confined to junior employees, exemplified by Professor Hahn's recollection of a terrible run-in with a Deputy Chief Medical Officer who demanded a list of the patients so that he could disseminate them to all dental surgeries. While efforts were made by clinicians and nurses to combat the stigma, and the attitudes described were far from universal, the boards recognise that overall the effect of stigma in compounding the already immense suffering experienced by the families as a result of the infections cannot be overstated. And this only served to aggravate and compound the awful suffering experienced by the children and their families. Finally, in this chapter, a word on hepatitis infections acquired through blood transfusions. The Penrose inquiry estimated that 2,500 patients were infected with hepatitis C by this means prior to the introduction of blood donation screening in 1991. In addition, 18 patients were infected with HIV by blood transfusion. Many of those patients were exposed to infections by receiving transfusions of blood or blood components in the course of surgical procedures or other non-routine medical care where there were no particular arrangements for routine follow-up by way of testing or monitoring of the kind available, for example, in the context of haemophilia care. In this regard, the inquiry has heard multiple accounts from patients and their families of difficulties and delays in obtaining a diagnosis after developing symptoms of the disease. It is important to recognize that many of those affected in this way were women, often infected through transfusions given for intrapartum or postpartum complications. In some cases, symptoms were misattributed to unrelated causes. Following diagnosis, questions from doctors about lifestyle factors such as drug use and promiscuity could make patients feel stigmatized or anxious that the true source of their infection had not been recognized. Moreover, the inquiry has heard evidence of numerous instances where lengthy and apparently unexplained delays may have occurred in communicating a diagnosis to patients following testing. Some patients infected during the 1980s were only diagnosed following the UK-wide look-back exercise undertaken in 1995. The boards wish to apologise for the suffering experienced by patients as a result of the delays in diagnosis, and it follows in access to NHS treatment for patients infected with hepatitis B and hepatitis C through blood transfusions. And I want to turn to the last chapter in the board's written submission and to say something about recommendations. I conclude, sir, on what may be, at least perhaps, a more positive note, recommendations for the future. The board see the recommendations by this inquiry as being of particular importance, not least because a substantial number of the infected and affected core participants are current patients of the NHS in Scotland, and in the process of recommendations, they perceive a unique opportunity to secure improvements in those patients' experience and the standard of care and treatment provided by the boards. For that reason, the boards are grateful to have been given the opportunity both to propose their own recommendations for your consideration, sir, and also to comment on the recommendations proposed by other core participants. In our written submissions, we do both. In our submission in June, we proposed several outline substantive recommendations for you to consider, and we adhere to these in our closing submission. I know that you will have seen and considered these, but in case it's of assistance to those watching who have not had an opportunity to read the written submission, our proposed recommendations for the future relate to 7 specific areas as follows. Firstly, encouraging the reporting of adverse events to the National Haemophilia Database, NHD, and the European Haemophilia Safety Surveillance, with the acronym EUHASS. Secondly, that specialist psychology support for the infected and affected should be directly available via all haemophilia centres for infected and affected members of the bleeding disorders community, with the necessary funding to enable consistent and sustainable delivery of this service. Thirdly, funding for specialist bleeding disorders physiotherapy services for people with bleeding disorders. I note the comments made by David Johnson King's Council expressing the support of the Scottish Government to the Thompsons' proposal in relation to this matter. Fourthly, the establishment of regional networks of haemophilia clinicians in order to help clinicians with decisions regarding complex cases and to assist in policy decisions at individual centres. Fifthly, developing clinical guidelines by supporting the UK HCDO and British Society for Haematology with the resourcing necessary to carry out their roles in producing guidance on the optimal treatment of people with bleeding disorders. Sixthly, clinical audit. We recommend that regular audit of standards of care should be performed in centres treating people with bleeding disorders. And seventhly, that there should be prescription of recombinant coagulation factors in favour of plasma-derived ones where clinically appropriate, and that service commissioners should ensure that such treatment decisions are funded accordingly. As they undertook to do, the boards have also carefully considered the recommendations proposed on behalf of the Thomson's core participants and provided our comments. By way of brief overview, you will have seen that there are a number of their proposed recommendations with which the boards agree and consider that the recommendations would assist in improving the experience of patients, and areas where aspects of the proposed recommendations overlap with our own, such as in relation to the provision of psychosocial support services and physiotherapy services. The boards also endorse those recommendations in relation to a long-term monitoring for the affected and infected and the testing of carers. There are others of the Thomson's recommendations which we suggest may require some modification in order to be effective in achieving their goal. For example, to enable consistent and sustainable delivery across the NHS in Scotland, such as in relation to palliative care provision. Again, sir, you'll recall that David Johnson, King's Counsel, who spoke on behalf of the Scottish Government, touched upon palliative care in his closing statement last week and made reference to the new strategy steering group for palliative end-of-life care. And finally, there are some proposed recommendations on behalf of Thomson's where we feel substantial improvements have already been implemented in the areas where shortcomings have been identified. In those areas, we would submit that it is important that any recommendations which may be considered appropriate or required at all should take account of and reflect the current position in these areas. In that connection, if there are any other matters in relation to which the Chair considers the boards may be able to provide further assistance going forward, I can say they will be happy to do so to the best of their ability. That, sir, is everything I want to say in part 2 of my closing statement, which concerns the boards. I'd now like to move on to part 3 of the closing statement, which concerns SMBTS. Before making my specific comments on behalf of SMBTS, I'd like to preface those comments with a few introductory remarks. In this closing statement, SMBTS wishes to highlight certain points from its written submission it considers to be important. The comments will be at a relatively high level. For reasons explained in part 1 of this closing statement, and which I hope are obvious, the focus will be on what went wrong as opposed to what went right. And in that regard, SMBTS sincerely apologises to the infected and affected for those areas where it believes the organisation fell short. Like the boards, SMBTS has given careful consideration to the issues and has tried to be fair as it can in its assessment of its past performance. In preparing for these hearings, Professor Turner, whom I mentioned at the outset of my closing statement, amongst other things, reviewed the written submission prepared by Mr. Dawson, King's Counsel, on behalf of the Scottish infected and affected, represented by Thomson Solicitors. This was done as a matter of priority, and by way of overview, I can simply say at the outset that SMBTS is in agreement with Mr. Dawson about a number of matters which I will highlight in due course. So if I may turn then to the areas that I would like to say something about. The first area I would like to say something about concerns blood donation and donor selection. I want to begin with some comments about blood donation and donor selection. In this first chapter, I intend to submit upon three matters which fall together under the broad heading of donor selection. SMBTS has reflected upon the evidence relating to this area, in particular the period prior to the introduction of viral screening of blood donations. Upon consideration of the evidence, SMBTS has identified three specific areas where it fell short, and it would like to take this opportunity to recognise and apologise for these. Firstly, intravenous drug use. In relation to this, SMBTS recognise and accept that during the 1970s and early 1980s, there was insufficient systematic face-to-face questioning of donors in relation to the issue of intravenous drug use. This was so even though an association of intravenous drug use with hepatitis B infection had been recognised from at least the early 1970s, and that a recent or current history of physical evidence of intravenous drug use were included amongst the grounds for exclusion in the blood services procedures. In the submission of SMBTS, it would have been better if they had excluded intravenous drug users much earlier than they did, and that this should have been achieved through the introduction of a more systematic donor selection processes across all SMBTS regions. No date is specified in the written submission, but the position of SMBTS is that an appropriate date for that to have been done might have been by the mid-1970s. And on behalf of SMBTS, I apologise for the failure to do so. Secondly, the subject of prisons. It is the case that from 1957, SMBTS collected blood in prisons. They only stopped doing so between December 1981 and March 1984, depending on the particular regional blood transfusion service concerned. SMBTS accepts that the organisation should have stopped collecting donations from prisons much earlier. Arguably, this should have happened by 1975, by which time evidence of high HBV prevalence amongst prison donors had clearly emerged. They apologise. SMBTS apologises unreservedly that this was not the case. One further point on this, if I may. SMBTS regards the principle of voluntary non-remunerated donation as a key ethical principle, and along with careful donor selection, an important contribution to blood safety. They have no intention now or in the future of collecting blood from people in penal or other institutions. In this respect, also, they find themselves in agreement with the position adopted by Mr. Dawson KC in his written submission, and for completeness, it's at page 1189 of that document. Thirdly, the AIDS leaflet. Of course, the inquiry has spent considerable time looking at the process by which an AIDS leaflet was produced for blood donors across the UK and the reasons why it took so long. By way of background to the particular perspective of SMBTS on this issue, you will recall evidence that in the early 1980s, there was a particularly high prevalence of HIV infection in Edinburgh. And in May 1983, the Edinburgh and South East Scotland Blood Transfusion Service, under the leadership of Dr. Brian McClelland, worked with clinicians specialising in sexually transmitted diseases and also with representatives of the gay community in Scotland to develop a leaflet asking specific groups of people at higher risk of AIDS to refrain from donation. In our submission, this was important early work in terms of responding to the emerging risk of AIDS by way of donor selection policy. Unfortunately, the other Scottish regional transfusion centres chose not to adopt the leaflet at that time, and so its circulation was initially restricted to Edinburgh. And so SMBTS regrets that these early leaflets were not more widely adopted across SMBTS prior to the release of a UK-wide leaflet in September of 1983. The SMBTS wishes to apologise for this delay in implementing this important measure throughout Scotland. Finally, before I leave this topic, may I turn to say a few words about current donor selection practices within SMBTS. In his written submission on behalf of the Scottish Infected and Affected Corps participants, Mr. Dawson highlights at paragraph 15 2 points of particular importance with which SMBTS wish to record its agreement. Firstly, the importance of measures which seek to improve donor engagement. And secondly, the importance of sufficient investment of resources to maintain the system in which they, the donors, play such an important part. SMBTS see that as no less than an essential aspect of their duty of care to the 100,000 people in Scotland who regularly donate blood, altruistically, in order to support the lives of others. So we agree with Mr. Dawson and indeed recognise and wish to emphasise before you today, sir, how the issue of donor engagement is of absolutely critical importance to the blood service in Scotland today, given the major challenges to self-sufficiency currently being experienced by blood services in the aftermath of the COVID pandemic. SMBTS undertakes to continue to work on its engagement with its donors and the general population in Scotland to encourage people to donate blood, tissues and cells, and to enhance understanding of sufficiency, quality and safety issues, recognising that the nature of this engagement will continue to evolve in response to broader changes in technology and society. I now want to turn on to the second chapter and discuss under the heading of donation screening. And the first issue I want to talk about in relation to donation screening is surrogate testing for non-A, non-B hepatitis. In the written submission on behalf of SMBTS, the benefit versus risk debate surrounding the introduction of surrogate tests was very difficult to resolve in the absence of adequately powered prospective UK clinical studies. As a result, the uncertainties relating to the sensitivity and specificity of ALT and hepatitis B core antibody testing continued to prevail. And this made it difficult for the blood services to reach a concluded view as to the likely utility of the test in preventing transmission of non-A, non-B hepatitis. SMBTS advocated for studies to be carried out in the UK to try to resolve this problem. For example, studies similar to the transfusion-transmitted virus study which was carried out in the United States from 1981 onwards. However, SMBTS was not in a position to progress these without external funding and support from the government. In our submission, it would have been right for these or similar studies to have been supported with the necessary funding in order to allow informed decisions to be made in a timely manner. SMBTS regrets that these studies were never carried out. Overall, however, SMBTS has reached the view that on balance, in the absence of such data, and with the accumulation of evidence of the long-term effects of HCV infection in some patients, surrogate testing should have been introduced in Scotland as a precautionary measure. And SMBTS is of the view that this should have been done by 1987. By way of background, this is discussed, sir, in paragraph 110 of the SMBTS written submission, and I'd simply note that in 1987, a letter was written to the Lancet from the SMBTS directors in which it was agreed that whilst the size of benefit to be gained by surrogate testing could not be accurately established without the type of study proposed in 1981, the time for such a study had passed and testing was inescapable. So that was the view that was expressed by SMBTS in that letter in 1987. In reaching the conclusion that I've described, namely that surrogate testing should have been introduced in Scotland as a precautionary measure, it's acknowledged, of course, the problems with the data and that professional opinion was, and indeed probably still is, divided on the issue. However, the key point here, it seems to us, is that while surrogate testing could not have eliminated the risk of non-A, non-B transmission in Scotland, it would probably at least have mitigated it to a certain extent. And for that reason alone, it would have been something worth doing. Although we entirely accept it is difficult to conclude with certainty that what the magnitude of the benefit would have been. And again, just by way of assisting you, sir, hopefully to understand the different perspectives, You heard, of course, Mr. Charlie Corey-Wright, KC, on behalf of NHS BT. My understanding of their position is that they would say there were good reasons for not introducing surrogate testing, and they note that the prevalence of HCV was likely to have been higher in Scotland than England due to the higher level of intravenous drug use, meaning that the calculation into introducing a test was differently balanced potentially in England as opposed to Scotland. And for completeness, Justice Burton, about whom there has already been some discussion from the case of A against the National Blood Authority, his view was that surrogate testing should have been introduced within the United Kingdom no later than March 1988, just for completeness. In his written submission, at page 427, Mr. Dawson advances the criticism that there was a failure on the part of SMBTS in not communicating more clearly to the government the reasons why its directors considered it appropriate for surrogate testing regime to be instituted. Having reflected on Mr. Dawson's submission, SMBTS has concluded that the criticism he makes is justified, and the SMBTS wishes to apologise for their failure on that part. I now want to turn to the second topic under donation screening, that is HCV testing and the theme of delay. In relation to this subject, we say, first of all, and this I suspect may not be all that controversial, that much greater urgency should have been given to the implementation of HCV testing. As SMBTS say in its written submission, it's frankly difficult to understand why it took more than 2 years to achieve this, even in retrospect, and with the benefit of the inquiry's forensic examination of the relevant timeline. Upon consideration of that evidence, it remains unclear to SMBTS why it would not have been possible to, in principle, to introduce a first-generation test as early as around March 1990, which is consistent with the date identified by Mr. Justice Burton in the National Blood Authority case. But in any event, by April 1991, at the latest, as initially recommended by the Advisory Committee on the Viral Safety of Blood in November 1990. And you will have seen, sir, that in relation to the second date, the April 1991, we deal with that at paragraph 118 of our written submission. And there's reference there to the fact that in its meeting of 21st November 1990, the Advisory Committee on the Viral Safety of Blood further recommended implementation of HCV testing with a potential start date of the 1st of April 1991. By way of further brief comment in relation to the earlier date that I've touched on, around March of 1990, I simply paused to note that April of 19, in paragraph 116 of the written submission, it's noted that in April 1990, the NBTS study concluded that the first generation test had an acceptable level of sensitivity and specificity. And then the second point for completeness in relation to the March 1990 date that identified by Justice Burton, that is consistent with as I understand, the dates of implementation by France and Luxembourg and the other European and foreign countries identified in the IBI chronology, just for completeness. The inquiry has, of course, examined the relevant chronology of events leading up to September 1991 at a granular level of detail, but from an admittedly more high-level view, it does appear to us that the excessive length of time taken to introduce the screening appear to be mainly related to delays in decision-making by the Advisory Committee on the Virological Safety of Blood, and also the UK's government's instruction to comply with a single UK-wide implementation date. In his final report, Lord Penrose criticised SMBTS for not more robustly arguing the case for having earlier implementation of HCV screening in Scotland by 1st April 1991 at the latest, and for not making a formal request to the SHHD, the Scottish Home and Health Department, to be allowed to do so. SMBTS accepts the criticism and apologises for those failings. Before leaving this topic, can I perhaps say something about current donor screening? As you may know, sir, the decision as to whether or not to implement new donor screening in Scotland rests ultimately with the Scottish ministers and government, usually acting on the advice of the UK Advisory Committee on the Safety of Blood, Tissues and Organs, called SABTO for short. Nowadays, the current residual risk of missing a transfusion-transmissible infection with current donor selection and screening procedures in the UK is generally low, as evidenced by the UK Serious Hazards of Transfusion short hemovigilance system. Nevertheless, it is also the case that the risk of transmission of infection by substances of human origin cannot be completely eliminated because of limitations to the sensitivity of assays, the emergence of new infections, and continuing genetic evolution of established infectious agents, as we've seen in the emergence of the COVID-2 and its variants over the past 2 years. Moreover, the risk of transfusion or transplantation transmission of infection is contingent on the prevalence and transmission of infection in the general population, such as we see, for example, in the foodborne transmission, BSE or VCJD, and hepatitis E. And that is something that can go up as well as down, particularly when new diseases emerge and become established within the population. SMBTS supports a precautionary approach to all aspects of blood, tissue and cell safety, both in regard to the individual recipient and broader public health concerns. In this regard, and for example, we note that in his submissions on recommendations, Mr. Dawson advocates in favour of early adoption of new donor tests, by which we understand him to mean microbiological tests. SMBTS agrees with this submission in principle as an appropriate practical application of the precautionary principle. However, and looking at matters more broadly, it is a regrettable fact of life that the healthcare system is financially and operationally constrained. As a result, all commitments of resources elicit what might be described as opportunity costs in terms of other potential health benefits which need to be foregone. There are therefore broader societal considerations around the extent to which society wishes to accept a risk and or assume the costs of mitigation. And that is something which unfortunately remains as true today as ever it was in the past. It's against that background, sir, that SMBTS invites you in its written submission to consider the nature and appropriate level of tolerability of risk in regard to transfusion, stroke, transplantation, transmitted infection, the extent to which conventional cost effectiveness calculations can be or should be applied in the area of transfusion transplantation safety, and the broader societal responsibility to mitigate the prevalence of serious infections. The reason why cost effectiveness is so important in the calculus is because SMBTS is highly financially constrained. And certain fundamental questions perhaps need to be asked, which would include, given the fact that a risk cannot be eliminated completely, what is an acceptable level of risk and to whom, and how do we weigh affordability and cost effectiveness? And is the risk-based decision-making framework the way forward, as I understand NHS BT say it is and SMBTS say it is? The third area that I wish to look at is look back. I'd like to say something about the hepatitis C look back exercise, and also from a current perspective, the issue of look back more broadly. In relation to the HCV look back, which was not launched across the UK until 1995, we first of all observed that the principle of tracing recipients of potentially infectious blood had already been established back in 1985, when a look back for HIV was carried out at the same time as the screening of blood donations for HIV was introduced. When HCV testing was first introduced in September 1991, a look back was established in the Edinburgh Regional Transfusion Service at the same time. The question which the pilot study set out to address was whether the same approach to HCV was logically feasible, and that question was answered in the affirmative by the outcome of the study. The fact, sir, that this was possible, the fact that it was possible to achieve this in Edinburgh at that time informs our view that look back could and should have been attempted throughout Scotland from September of 1991. And I just pause to say the reason I have used the word attempted is because it would have been a more difficult exercise elsewhere in all likelihood, especially in the absence of resources. Unfortunately, however, in reality, it was very difficult for SMBTS to progress this policy unilaterally and without the necessary resources, in light of the decision in 1991 by the Advisory Committee on the Viral Safety of Blood and the UK government to reject HCV lookback as a policy, and given the need for involvement of other NHS organisations which are not under the direction of the blood services, such as hospital blood banks, public health, and secondary and primary care and vital functions of the look-back exercise, such as tracing, testing, and counselling recipients. For these reasons, sir, SMBTS regrets that a Scotland-wide look-back for hepatitis C was not undertaken in 1991 and in any event much sooner than 1995. Finally, a word on look-back from a current perspective. Whilst the potential transfusion-transmitted infections to SMBTS routinely leads to a specific investigation and look-back, it remains the case that large-scale systematic look-back is a challenging undertaking even today. The conduct of large-scale look-back still requires additional resources and a systems-wide approach involving blood services, public health services, relevant clinical specialists, government primary and secondary care. The European Blood or Tissue Directives or related UK legislation do not currently mandate or even describe the circumstances in which look-back should be carried out. Moreover, the decision as to how far back look-back should extend is a difficult balance of the ethical, legal, and medical imperative to inform a person who may have been put at risk of infection against the diminishing practicality and cost benefit the further one goes back in time. In addition, whilst current donors will be tested using a new assay, lapsed donors will not and represent a very large cohort of people. In its written submission, SMBTS invites you, sir, to consider in your report the circumstances under which a systematic look-back should be carried out, the scope of such look-backs, and the extent to which cost-effectiveness should be considered alongside the views of blood recipients and broader ethical, legal, operational, and societal considerations. The question raises similar issues as I've mentioned in relation to testing. Given sufficient resources, we could, of course, trace and test everyone in Scotland who had given blood. But in reality, the opportunity cost would be enormous and would take resources away from current priorities, for example, treating the 12% of the Scottish population now on a waiting list. So the question is, does the inquiry accept that a line has to be drawn, and if so, how is that to be done? This is an issue with which the blood services wrestle with all the time in the context of SABTO. SMBTS also invites you to consider whether or not, or to what extent, the duty to perform systematic look-back could or should be included in relevant legislation. Now, sir, I'd like to turn to a new chapter. I want to talk about processing capacity at the Protein Fractionation Centre, PFC. As we explain in the written submission, it was generally the case that over the period between 1975, 1976 and 1987, 1988, SMBTS was able to manufacture blood products in sufficient quantity to meet average demand in Scotland, if both factor VIII and cryoprecipitate are taken into account. However, clinical preference and requirements meant that commercial concentrates continued to be prescribed in Scotland over this period. The inquiry has, of course, examined the question of why the plans for PFC to fractionate substantial quantities of plasma from England never materialised, as had been envisaged at the time when PFC was first commissioned in 1975. It may be that you will conclude that this was in itself a factor which limited or slowed progress towards self-sufficiency at a UK level. I don't wish to stray too far into the detail on this topic, which is before you in the evidence, but suffice it to say that SMBTS is of the view that it would have been possible to significantly increase the capacity at PFC to help process plasma from England as originally planned if there had been, firstly, appropriate investment in facilities, and what I mean by that is specifically the freeze drying capacity, and secondly, the introduction of shift working at PFC, such as to enable a 24-hour production cycle to be brought into effect. SMBTS is of the view that this was a missed opportunity for PFC to fulfil its potential to contribute to to contribute to the progress towards self-sufficiency across the UK as a whole, and the organisation regrets that this did not happen. I now want to turn to say something about viral inactivation and the 8Y issue. This is not a matter which we discuss specifically in the SMBTS written submission. However, it's a matter which Mr. Dawson draws attention to in his submission, and I've been asked by SMBTS to address it in my closing statement today. The background to this matter is, of course, that in September 1985, the fractionators at PFL and BPL became the first in the world, as we understand, to manufacture a factor VIII product, 8Y, which was later known to be safe from non-A, non-B transmission. The development of an equivalent factor VIII product by PFC, a concentrate called Z8, took a further 20 months. Largely because the two manufacturing processes were not the same, and therefore the BPL process could not be directly transferred across to PFC. There were also a number of other development problems which took time to address, as you have heard. In Mr. Dawson's submission at page 732 to 735, he argues that once the comparative safety of the 8Y product in regard to non-A, non-B transmission became apparent, BPL should have been approached either by SMBTS or by the haemophilia directors to allow a small supply to be put in place in Scotland to meet the needs of untreated or minimally treated patients prior to Z8 becoming available. And that is to say, and to be clear, a separate supply for the benefit of all haemophilia patients beyond the 50 vials which were obtained for the use of Professor Ludlam in the summer of 1986. SMBTS has concluded that there is force in the argument which Mr. Dawson advances in his submission. SMBTS therefore accept the criticism that is made, and whilst they do believe that this was an area of shared or collective responsibility with the haemophilia directors, they wish to apologise for their failure in this regard. That is everything I want to say about that topic. I now wish to say something briefly about product labelling, information and warnings in relation to PFC. By way of a very brief introduction to this topic, you'll recall the evidence given to the inquiry to the effect that during the period in question, hepatitis warnings were included with PFC products. However, it was not until 1985 that any specific warning given of the risk of infection was any specific warning given of the risk of infection from AIDS, HIV from SMBTS products. Now, it is the case, as explained in the evidence, that whether rightly or wrongly, the information provided in product leaflets, labels and packaging at that time was primarily designed or intended for prescribing doctors. However, SMBTS accept that the warnings should have been much more explicit in drawing attention to the risk of AIDS, HIV, and hepatitis, in particular non-A, non-B hepatitis. In the first place, SMBTS do accept that many doctors, in particular those outside the main treating centres or more junior doctors, would have benefited from clear information to this effect. Moreover, SMBTS also accepts a point discussed again by Mr. Dawson at page 759 of his written submission, that with the advent of home treatment, there was an opportunity to make information on risk directly available to patients, and that was an opportunity missed by SMBTS. The view of the current SMBTS management is that whilst the labelling of plasma products in the 1980s was consistent with the practice of other plasma product manufacturers and compliant with the regulatory standards of the time, it would not be considered sufficient by modern day standards. And SMBTS accept that the warnings given certainly could and should have been much more explicit, and they apologise that that was not the case. And that is everything I want to say about that topic. Hopefully, relatively briefly, I can turn now to self-sufficiency, which is, of course, a very important topic that goes to the heart of many of the issues which you require to determine upon, and not only in relation to the position in Scotland. First of all, I reiterate that for SMBTS, voluntary non-remunerative donation is a fundamental ethical principle on which their service is based. It is, of course, an essential role of SMBTS to maintain, as a matter of clinical imperative, sufficient blood component stocks to meet elective and emergency demand for all blood components and compatible blood groups throughout Scotland at all times. Scotland's unusual geography means that it's no easy task. A person involved in a road accident in Shetland requires the same availability of life-saving blood components as they would in central Edinburgh. And for this essential function, SMBTS is dependent on the altruism and generosity of blood donors to sustain this. It's true to say, of course, that while voluntary donation is undoubtedly safer than paid donation, there will always be risks associated with any donation of blood and other substances of human origin, such as cells, tissues, and organs, as the evidence you have heard, sir, serves to demonstrate in the most tragic way imaginable. SMBTS recognise that they owe a duty of care to both donors and recipients to mitigate these risks so far as possible, and that respect for the principles of precaution and informed consent lie at the heart of this. As you will know, sir, Scotland has been historically predominantly self-sufficient in the provision of blood components and remains so today. For other substances of human origin, such as tissues, cells, organs, and specific products frequently supplied across the home nation boundaries. In that sense, the concept of self-sufficiency is realised today on a UK-wide basis. The inquiry has heard a substantial amount of evidence in relation to the question of if and when self-sufficiency of plasma was ever achieved in Scotland during the critical period under examination. The position of SMBTS, if I may summarise it very briefly in a nutshell and in admittedly broad general terms and without straying into the definitional complexities, is that in the period between 1975/76 and 1987/88, there was generally sufficient plasma available in Scotland to meet average clinical needs using only donations from voluntary, non-remunerated donors if production of both coagulation factor concentrates and cryoprecipitate are taken into account. However, SMBTS would also accept that largely as a result of the twin challenges of rising clinical demand and the continuing prescription of commercial concentrates by doctors in the exercise of clinical judgment, meant that the objective of, quotes, full self-sufficiency of plasma remained elusive. It may therefore be that near self-sufficiency, as Mr. Dawson describes the position in his written submission at page 4 might be a better way to describe the situation in relation to domestic plasma production in Scotland during this period. But that is, of course, a matter for you, sir. And finally, the last topic that I wish to say something about, which I will be able to do before 1 o'clock, is clinical transfusion practice. The evidence, sir, given to this inquiry has cast into sharp relief the extent to which historical clinical transfusion practice was at the least variable, particularly when compared with current practice. In particular, we suggest the evidence has highlighted problems with high rates of blood transfusion, weaknesses in the clinical transfusion process, and inadequacies in informed consent. And what we wish to emphasize today, and from today's perspective, is that whilst current clinical transfusion governance practice has enhanced the quality and safety of the clinical transfusion process, there are still areas where improvements can and should be made. In the written submission, and indeed the SMBTS Organisational Rule 9 statement, SMBTS highlight the important role played by the Serious Hazards of Transfusion Hemovigilance System, also known as SHOT. Today, the majority of reports to SHOT, indeed in excess of 80%, are now due to errors or mistakes in the clinical transfusion process. The biggest risks are receiving the wrong blood, either wrong component transfused or specific requirements not met, receiving too much blood too quickly and developing transfusion-associated circulatory overload, or TACO for short, or not receiving blood quickly enough, blood delays. We have to recognise that there is yet work to be done in relation to informed consent. Shared decision-making and consent in clinical transfusion practice was recommended by SAPTO and by NICE in their blood transfusion guidance and supported in Scotland by Realistic Medicine. Yet successive audits, including a recent audit against the NICE quality standards, has demonstrated that less than universal compliance. NHS, hospital and staff continue to be under exceptional pressure, perhaps never more so than over the past few years. However, most of these systems errors are preventable with the right processes, knowledge and training, as well as implementation of enhanced electronic clinical systems which promote and support best practice in the laboratory and at the bedside. And it is with issues such as these in mind that SMBTS would invite you to consider in your final report the extent to which blood sufficiency, quality and safety are functions of the healthcare system as a whole, and the ways in which intelligence from appropriate blood usage and patient safety data from local and UK hemovigilance systems can be better used to inform changes in healthcare systems, policies and practices. That, sir, brings me to the end of what I wish to say to you today, and I hope that these submissions have, or this closing statement has been of some assistance. The boards and SMBTS wish to conclude by saying that they look forward to reading your report, sir, and of course if there are any other matters in relation to which the boards or SMBTS may be able to provide you with further assistance, they will be happy to do so to the extent that they are able. Thank you for listening.
Well, thank you. As you know, we've heard quite a lot, particularly more recently in the inquiry, about the whole question of candour, which involves, I have been told, not only being candid, but deserving trust of those who have placed their faith in the services they get. It seems to me that by what you've said today and what you have written in greater detail and with plain consideration and reflection, with the assistance or on the instructions of your respective clients, the health boards and the blood services, you've demonstrated that candour. It will, as you say, be for me to decide what I accept, what I reject. But I have to say that your clients can be thanked for being prepared, as others perhaps might have been, to say what, not only that they apologise, but what they have actually apologising for. And you'll see that I thought there was a clap beginning there, which I think your client deserved. And that, I think, says a lot. So thank you. We'll take a break until 2 o'clock.